So, when we talk about this topic, I would say first prevention is better than cure. Rather than struggling after a complication has happened, it's always better to prevent it before it happened. So, next slide. Next slide. Not moving, sir. Okay. So, how can we prevent those unsatisfied patients? It can be in the preoperative care, by intraoperative care, and postoperative care. So, in preoperative care, by doing a good slit lamp evaluation, many of subtle things which we take it for granted can sometimes cause a lot of problem postoperatively. Like for example, the simple conjunctivocalysis, it's just nothing but a redundant loose conjunctiva which happens with aging, or chronic irritation and tearing can cause this conjunctivocalysis, and these patients are one of the most unhappy patients postoperatively, complaining of lot of discomfort and irritation. So address this preoperatively and warn the patient. So they might have watering issues. Sorry, they might have watering issues, so that they don't question you much at the end of the surgery. And then we have to do a good slit lamp evaluation to see for Gutay or any fuchs endothelial dystrophy to avoid unnecessary post-op complications. We have to see for faint scars, so that patient don't complain that I don't have 100% vision, because this is the era which we're dealing with. Refractive cataract surgery, gone are those days when they did a cataract surgery for just to improve the visual acuity. And please look for pseudo exfoliation, and please warn the patient that they have to come for a regular IOP check postoperatively, because it has been reported in literature that 26% of the patients with the pseudo exfoliation can end up with glaucoma postoperatively. And then comes the lid hygiene. So a proper and thorough good lid examination is mandatory, because these are patients who can end up with complications like end of, or might trouble us with chronic irritation and watering. And then dry eye examination. Dry eye examination is part of for regular preoperative workup, and patients with dryness preoperatively are warned about the postoperative need for medicines for a few months at least. And then do a good fundus evaluation. If fundus is not seen preoperatively because of the dense cataract, we have to definitely put a word to the patient that their retina has to be examined at the end of 1 month during their follow-up, so that there is no questioning or there's no argument after the 1 month of the surgery, why is my vision not improving, and why was that not explained earlier. And this is one study which reported that they have done macular OCT for patients who undergone cataract surgery, and they found a lot of macular pathologies which was missed or underestimated by standard fundus examination. So many times when the media is hazy, we just report it as foveal reflex dull, but then sometimes a macular hole or a mild macular edema could be missed. So it is an ideal choice, at least in premium IOLs, to have as a regular practice to do an OCT prior surgery. And explain the IOL choices to the patients. And so first, understand their needs, and then explain all the options available and make them comfortable financially, reassure them and allow them to decide. And if there is any astigmatism, explain them about the option of toric IOL or the postoperative glasses. And then the preoperative, these are simple tips. This can make them unhappy even if you do a good cataract surgery at the end of the day. So the patients have to be clearly explained about the pre-op topical medicine, timing of surgery, venue, food intake, medicines, and topical explanation. And intraoperative care, I would stress this, because practically less waiting time and following good theater disciplines also matter a lot coming to an unsatisfied patient. If they have some unhappy experiences during the surgery, also they tend to be unhappy with the course of the surgery, even if they are 6 later on. Even after doing all these, we encounter unhappy patients, and that is the topic which I'm going to talk here. So the post-operative unhappy patient could be an early unhappy patient or a late unhappy patient. So early unhappy patients are one because of refractive surprise, dysphotopsia, aberrations, and late unhappy patients could be because of dry related issues. So why refractive surprise? Like Sir said, a 1 millimeter difference in an axial length can cause a 3 diopter difference in the IOL power calculation. So a prior good K reading, axial length, and IOL power calculation is very important. So it is mandatory to do a good IOL power calculation. And if there are issues like a long eye or short eye or a post retinal surgery eye or a previous refractive surgery, We have to take effort to do a good IOL power calculation with the latest technologies available in the market, and then go ahead with the surgery to avoid unnecessary post-operative refractive surprise. And then the correct IOL has to be inserted. So for post LASIK patients, the expectations are also high, and the corneal power is overestimated and the IOL power is underestimated because of the flattened cornea. And so in post-operative patients, we follow the Barrett's formula, which is available free online. So um, so this is the Barrett's Truque formula, which is available online, and it is very simple to use. They just ask few data, which, as Jaintan sir told, that they are available in optical biometers. The Truque value, white to white, and certain values, which is self-explanatory. Those details have to be provided, and then that gives the formula, the right IOL which we have to insert. So. Why is it moving fast? It is moving by itself, I think. I didn't touch. Okay. See, it is moving fast. I'm not doing. Okay, so what they say is, for refractive surprise, if the surprise is less than 2 diopters, then it is better to go in for a non-invasive procedure like a LASIK or a trans-PRK. If the refractive surprise is more than 2, then it is better to go in for other options like a piggyback IOL or an or a piggyback IOL or a lens exchange. So as I told, if the refractive surprise is less, it is better to go for a LASIK or a trans PRK. And corneal surgeons prefer a trans PRK. Sorry. If we have a post-operative surprise, so the first thing we say, we try to convince the patient or reassure and provide them glasses. But if they are very motivated to get to be without glasses, then we either give them an option of ablative surgery or an IOL exchange, or a piggyback IOL. So without doing it is going, sir. See, this I am not touching, but I don't know, that alone is going fast. Okay. Okay, so basically, if the refractive surprise is less, we can either give the patient an option of glasses, contact lens. If they are okay and if they are comfortable with that, we can just make the patient happy with only that. If the patient is not happy with glasses and contact lens, and if the cataract surgeon has an approach with has a LASIK machine, then he can suggest the patient to undergo LASIK or trans PRK if the power is if the refractive surprise is less than 2. The corneal surgeons prefer to do a trans PRK compared to LASIK, because they say for doing a LASIK, the wound has to be completely healed, and we should give a period of at least 6 months, because while doing LASIK, otherwise the wound might open up. Trans PRK is safer, it doesn't cause much IOP increase also. And piggyback IOLs are done for lens exchange. Piggyback IOL is nothing but placing another IOL over the already placed IOL. So when there is a refractive surprise, the amount of refractive error which has been created is measured, and then it's simple, and it's just put in the sulcus if it is a silicone, or in the bag if it's an acrylic. And it is relatively expensive compared to LASIK, but this can be done by anter-segment surgeries who do not have any access to a LASIK or a trans PRK. So the IL per calculation for piggyback is for hyperopic residual refractive error. The power of piggyback IOL is just by multiplying the desired spherical equivalent into 1.5. For myopic refractive error, it is the same as the spherical equivalent. But the contraindications for doing piggyback IOL is if there is already loose zonules, or if the bag is if there is a already torn PCR, if the bag is weak, or if there is glaucoma, or if the patient had poor endothelial count, it is not advisable to use a piggyback IOL. And the complications with piggyback IOL is interlenticular complication, like how we develop a primary capsular opacification. In between lens there can be opacification. It's called as the red rock syndrome. And pigment dispersion can be a problem which can cause glaucoma later on. Endothelial decomposition can occur. The piggyback lens also can dislocate, and glaucoma and hyphema or other complications. And if IOL exchange is another option if the refractive surprise is identified early and managed early. It is not a good choice if we have to do it after a later period, because the bag would be fibrosed, and so the exchange of lens might not be that easy. So IOL exchange can be done in the earlier period. The enlargement can be done, and the lens can be explanted if it is a rigid IOL, or if it is a hydrophobic IOL, or if it is a hydrophilic IOL with the already existing incision. A simple cut can be given, and the lens can be just withdrawn through the same section. And during IOL exchange, we have to be careful with the capsule posteriorly and the endothelium anteriorly. And as I already said, timing is very important. As with fibrous bag, we have to be definitely careful about the bag, because the whole bag can come. So we have to be prepared with other iris IOL fixing options. And dysphotopsia is another another problem which makes the patients happy every day. I mean, at least 2 or 3 times in a week, we always hear patients saying that I see rings, I see halos, or I see shadows. So positive dysphotopsia is the patients perceiving glare, halos, or ring-like thing. So it is basically because of the lens design, IOL design. So they say that the square-edge IOLs give more of these dysphotopsias, and lenses with higher indoor refraction causes more of dysphotopsia, and surface reflectivity also causes dysphotopsia. And negative photopsia, very often I hear patients telling that temporarily I am able to see some obstruction. So that is very common finding every day. Every day we hear this complaint. So this is caused due to reflection of the temporal light, and it occurs in patients with large angle kappa and nasal anterior capsule override and high aperopia. So in all these patients, the first thing is you give time to adapt. So neural adaptation is the one thing which we have to advise the patient, reassure them. And I will tell what to do for the other. So aberrations is one another problem which causes an unhappy patient. So aberrations can be detected by various machines. We had a wonderful talk by Jayanthan sir in the morning. So basically the aberrations, with those machines we should find whether we are having corneal aberrations or lenticular aberrations. So if it is because of lenticular aberrations, we have to probably think of an IOL exchange, or they say simple optic capture can also negate these kind of dysphotopsias. So how to manage? Yes, neural adaptation, and if not simple optic capture, or a lens exchange is an option. So take home message will be a proper preoperative workup, and evaluation is mandatory, and manage intraoperative complications with care, and do not panic when you see a refractive surprise. Reassure the patient, talk to them, do a good conversation, understand their needs, and then give up whatever we can from our side. And patient explanation and reassurance is ultimately the one which will help. Just I want to quote one thing. One high-end trifocal patient who used to come to my hospital always say that she sees sunflower after surgery. Now, when I was reading for this particular topic only, I realized there are so many things. So, but what I did was just reassurance and just gave her a glasses. But she used to come and meet me once in 3 months, happily going. So that reassurance is only the most important thing, rather than all these technologies. Have compassion and passion and talk to them. Thank you. Thank you for the